Good morning, everybody. How is everyone doing?
Thank you.
Awesome. Because we have so many amazing specialties here, I would love to ask you all to introduce yourselves, where you practice, who you see. Dr. Mara, would you like to start?
Sure. I'm Mara Tesler Stein. I'm a clinical psychologist and a PMHC. While I do still see some clients, I'm largely doing consultation and training. I'm based both out of the US and Israel. And my specialty is perinatal trauma, and I'm an EMDR trainer and consultant. And so my passion really is bridging that gap between the trauma therapists and introducing them and helping them to feel fluent in perinatal mental health, and then bridging from the perinatal clinicians into really understanding trauma focused treatments and integration with the perinatal period.
And I think that we might have an additional title for Leslie because she recently
Oh,
became
yes.
an EMDR trainer, but I will let her introduce herself.
Yeah, good morning. So my name is Leslie Pertz. I am currently in Ann Arbor, Michigan, which is about 45 minutes outside of Detroit. I am a clinical social worker and I have used EMDR for about the last 8 years, moving my way up through. I guess I never really thought about when I started my EMDR training 8 years ago that I would be an EMDR trainer myself. That's kind of how my career has gone. Different pathways of my life have come
Mm.
together to the path that I am on. I do a lot of telehealth. I am also a PMHC. I'm fluent in sign language. So that will be the first training that I start next year, is doing EMDR and ASL for deaf clinicians. And what else about me? A lot of the work that I do, my full time work, is seeing clients both on telehealth and in my home based practice. And I see also, as Mara does, a lot of perinatal trauma. I always say something went very, very wrong in pregnancy, either during pregnancy, before pregnancy,
Mhm.
during pregnancy, or after pregnancy. And then I also have this little niche that I keep growing, being in a medical town. So Ann Arbor has a big, big, big hospital system. Actually, I think 5 different hospitals all on one campus. And so I see a lot of healthcare workers and other therapists as well. So that's bridging that world between the personal and the professional. I'm excited to be here this morning.
Awesome. And Julie, go for it.
Sure. Good morning. My name is Dr. Julie Bindeman. I am a reproductive psychologist and the co director of Integrative Therapy of Greater Washington, which is located in Rockville, Maryland, a suburb of Washington, D.C. I see clients in person and virtually, but I'm doing a lot of consultation and I'm doing a lot of training, not EMDR training, but more so training around the reproductive period. It's not something that we get in grad school. And most of us are really unprepared when we have a client who happens to be seeing us and then maybe comes in with an issue that we hadn't heard of or we don't really know about. So I try to bridge that gap of not only clinicians that are interested in doing work in this field, but also just clinicians that don't want to specialize but still need the education. I also do a lot of third party evaluations, and I am the incoming chair of the mental health professional group of the American Society of Reproductive Medicine.
Cool.
Wow, good stuff.
I love that. And Julie, so I will start with you. You have this year-long course. I took it. I would take it every single year if I could.
Hmm.
It's amazing. And I'm wondering, have you noticed or seen shifts in the changing landscape of what reproductive health is currently looking like, given some of the changes or situations that are happening legally for your
Yes.
clients?
Yeah, we know that pregnancy comes with some risks. Just inherently in any kind of pregnancy, it comes with some risks. Those risks have been so accentuated by the laws that certain states have passed. So we are seeing people dying in pregnancy that don't need to die in pregnancy, but because the physicians are too afraid to lose their licenses, I get it. They're not getting the treatment they need in a timely kind of way. So they're not even the doctors aren't even able to follow the guidelines in which they trained with. The other change that I'm seeing too is really looking at states who might try to enact personhood laws, because that will impact IVF just in the same way we saw in Alabama earlier this year. So there's Louisiana also has personhood laws on its books. IVF has changed there from when those laws had passed, and it's a scary thing. When Dobbs came down, one of the first things some of my clients asked me were, "Are my embryos safe?" And my answer to that is, well, it depends on which state they're being kept in. And that's a terrible answer. The terrible thing for people who are trying to start a family or people who desperately want to have a child see that it's really risky, more so to do so now.
Thank you. Yeah, that's a really important point. And as we're continuing to see these things roll out, it's important that our therapists have places that they can get good advice. So, in terms of what people are seeing with TMFR, I know that we're all coming to it from different states. But Dr. Mara, would you like to just share a little bit about what you're seeing?
It's so interesting. I just came back from doing a 3-day workshop so giving a little perspective. I taught the advanced practice of EMDR for perinatal and infant mental health. And when we started to talk about termination and medical decision making, one of the things that the participants said was it was such a relief to hear me talk about abortion access and this idea of decision making, they said, because they've been so alarmed watching what's been happening in the US. And I'm based out of Illinois, and Illinois has actually put abortion access into its constitution. So, from my perspective clinically, my clients, my direct clients who are coming through, are not people who are going to be as directly affected. However, my consultees are all over North America and also in Europe. And so there's a lot of frozenness and fear that can happen clinically when what you want to do is provide the best support and be able to engage where the client's wounds are and where their needs are and where their uncertainties are. And then to have this feeling of these legal mandates that are different state to state. And I'm SIPAC licensed, even though again, I'm not seeing people all over the country so much anymore. You have to remember where people are located because it's a whole different ballgame. I think that for me, a lot of the process of supporting people through this sort of situation where there's something that has gone so wrong in a wanted pregnancy, about how does one think through decision making to have that interrupted and truncated because of what's gone on legally is another rupture. It's an ongoing rupture.
Thank you so much. Yeah, I think that's a really important perspective. And Leslie, what is that looking like where you see your clients?
Yeah, so being in Michigan, actually, I just came back from a conference last week. It was an in-person conference, and we were talking about this as a concept. There was maybe 100 or so therapists, healthcare workers, healthcare, the greater title of healthcare workers. So probably about 100 healthcare workers. And the presenter asked about abortion access in Michigan, and very few people knew what that looked like. So just to echo both what Julie and Mara said, even just asking the question, when I see consultees, being a social worker in Michigan, I only see Michigan clients, but when I do consulting, it's one of the first questions I ask too is, where are you located and do you know the laws in your state or the access in your state? I think it's one of those topics for all of us that we didn't have to think about a long time ago. I know that I didn't. Oh, we can access abortion up to how many weeks in this state? And so it was a question with this group of people that they didn't seem to know. And it was like, oh gosh, I have to know about this, or about documentation. Oh, I have to know about this. What are the legal ramifications? Oh, I have to know about this. So just echoing more so what Mara said about those wounds, it's not even just the experience, but maybe the access and the systemic issues that are becoming wounding to people as well. So it's a very interesting time.
So I'm wondering if you all would be just kind of give us some information in terms of what TMFR is, because I think that some therapists specialize in this and other therapists fall into this because they have had clients who are having this situation, right? So tell us a little bit about TMFR, and there's like this foundational level of like, how are we competent? And then there's this additional level of how do we become fluent in the language to help our clients process these situations that frankly nobody wants to be in.
And nobody's prepared for this. This is not what you expect.
Yeah, so just the acronym TFMR stands for Termination for Medical Reasons. And I think it is a way when someone has to make the choice to end a pregnancy that is usually desired, and that might be for a whole lot of reasons. It's a more medicalized way of describing an abortion without using the word abortion, because
Mhm.
that's such a politically polarized word in
Mhm.
the United States.
Mhm.
So it gives people some cushioning to be able to describe an experience that they've had
Mhm.
without feeling like they have to wade into the political fray.
Or the shame and the judgment that is so often attached to this word. Yeah.
Yeah. And it also, along those same lines, it gives a little bit of information to the listener that this has been a crisis for this family, that this is something bad has happened, even though it doesn't specify, and it can apply either to something very wrong with the fetus, the pregnancy, or the pregnant person. So it could be any number of things. And as Julie said earlier, a termination for medical reasons, there's lots of medical reasons, so many eventualities that can lead to that decision point.
What makes it really difficult too is people might get information that I like to kind of consider gray information, where what they're sort of told is, oh, we should monitor this, let's keep an eye on this. So it
Mhm.
might also be that people are living in this purgatory kind of state where they don't know if this is a pregnancy where everything's going to be fine, or if they might need to make a choice before the pregnancy naturally completes. So that's another piece of it as well. And of course, that
Mhm.
gets more into what state laws are and why it's so important to know what state laws are.
Yeah. And when thinking about what I've seen over the years, I've been doing this work for 26 years, so seeing a lot happen. There's also different trends I notice about how those conversations even go in the doctor's office or in the midwife's office in terms of sort of how much holding there is for families. And this may be answering a future question, but in terms of like, how are families held when either there's ambiguity and maybe they're going to get referred on to a higher level of care? How is that handoff? Are people just handed a business card and said, call this person for XYZ procedure? And people are like, what procedure? What do you mean? So there's so much. Just think about like how many opportunities there are for injury, for rupture, for disconnection, for isolation, along with the ambiguity and the gray information, like Julie said, and the gray areas of decision making too, by the way, which is a whole nother mountain of experiences to explore with clinicians.
That was the next thing I was thinking, is even the language of decision and choices, right?
Yeah.
Of sometimes using those words, or those words will get used with clients. And then almost every client that I've ever seen, this wasn't a choice. This wasn't a decision. These are not choices. These are
Mm.
no one wants to make these decisions. No one wants to make these choices. So many different layers, I think, of even just, we were
Mhm.
talking a lot last week at this conference I went to about mirroring language. I don't mean to
Mhm.
sidetrack our discussion, but just being able to all be on the same page about the experience and being able to define language, be it, I kind of think of it coming from, I don't know what access, but so much medical language gets passed down to people. Here's a syndrome, or here's a thing, or here's some very
Mhm.
high register medical language that's coming at people that they probably, words they've never heard in their entire life, or phrases incompatible with life, or different even chromosomes. Who knew that there was a trisomy 13? Who had ever heard of that before? But being able to, in some ways, translate that language while we're also translating the language that culturally gets used about choices and decisions and terminations and all kinds of other things.
Yeah.
I think that that's a really important point, Leslie, as you're talking about that language, and there are things that we were not taught in eighth grade health, right? So then we have these situations that are happening, and then we have states that are actively trying to not have this conversation. So I like,
Mhm.
what happens to Candy Miller? What happens to the
Mm.
people who are dying because they cannot get health care? So I'm interested in what are conversations that we should be having, that we can be having with the people who are servicing.
And I think again, that depends upon what state you're in. So if I'm
Mhm.
practicing in Texas, there's a bounty law where anyone, it's civil, it's not criminal. So anyone, if I were to give people advice about where to seek out even information about abortion or information about clinics outside the state where they might be able to attain care, I can be sued for $10,000 and I'm probably going to lose because of how the law is written. So it again creates this chilling effect, even for providers, just to give information.
I guess my question, because of where we are in our professional careers, is how do we support the people who are trying to support those people? And also, I'm licensed in Texas, so I'm just like, would rather not face a lawsuit this month. But yeah, I'm going to support that person who's going to that clinic. Frankly, most of the time for reasons that they would prefer not to have.
Mhm.
Who doesn't want to have a healthy baby, right?
Mhm.
And also, there are extenuating circumstances. So, how do we do that?
I start talking to people even
Mhm.
before they get pregnant about
Mhm.
speaking with their OBs, particularly if they're in states like Texas or Oklahoma or Alabama, because then they're not pregnant. It's all hypothetical. So these conversations can be had because it's a hypothetical. I also tell people to look at, there's a pro-life kind of a parallel to ACOG for gynecologists. And I say, hey, look, see if your doctor's on that. If so, you might want to consider changing doctors for pregnancy so that you can have options. I ask people to have conversations with their doctors about how will you direct me and what will you share with me? What information should we receive a poor prenatal diagnosis? What will you share with me? Because I've had clients where their physician hasn't said anything and it's like everything is fine. And it wasn't until they went to another place for a scan that they were told, oh, wow, things are horribly wrong. And the original OBGYN said, well, I don't believe in termination, so everything is fine. And it's baffling to me that someone can put their beliefs on another person. So, in terms of supporting people, sometimes it might even mean, hey, we support you in doing the work that you do and finding community so that you have on the ground other kinds of supports. And sometimes it might look like, okay, this might not be sustainable for you and your values. Let's think about other choices, either professionally or even geographically.
I love that framing because if my dermatologist could not work with eczema, I would go to a different dermatologist. But we're having this conversation where literally people's lives are at risk, and some people are not finding that voice to speak. So this is why I think that the conversation that you are all are having about TMFR and the course that you're going to be giving is so important to therapists. So can you tell us a little bit about how that came about and why this is important for, yes, therapists and also
For
the people who
everyone.
specialize in this, but it's going to be knocking at your door at
Mhm.
any moment, even if you're not a specialist in this area.
Absolutely. Did you two start talking about it first? I don't know. I think the two of you were talking about wanting to do this,
Well, I think
something.
it was even further back because we did that
Mhm.
presentation for EMDR Canada,
Yes,
and
that's
it
right.
was
That's
about
Mhm.
right.
terminating for medical
That was
reasons.
right.
Mhm.
That's right. Right.
Mhm.
And we really wanted to do something really comprehensive to really talk about the legal nuances in North America, but actually also then to really just get into, the clinical landscape of what happens medically, and then the range of what can happen emotionally. And then we made an outline.
To me, that feels like a formal way to say it, because even before that, long, way back, Julie and I connected with each other personally. This is about creating community.
Yeah.
Where I had a question about something, I was like, oh my gosh, I need to find out about this. And somebody's like, you need to talk to Julie. So I remember calling Julie up one day in the middle of a clinic day, and I was like, Julie, what do I do? Tell me about this. I had never heard her name before. Someone just said, here's Julie's name. You need to ask her this question. And I often feel that way about you, Mara. I just showed up in
Uh-huh.
Skokie.
You
And I
did.
was like, hey, okay, here we are. That these paths kind of just crossed
Yeah,
together, and we created community. So
you
not
did.
only creating community professionally, but creating community with the medical professionals, but as a therapist, creating your own community so that we don't have to feel that we're doing this alone. There's so many questions. They're like, what do we do with this? What do we do with this? What do we do with this? And even being in a state where abortion access is written into my constitution, into our state constitution, there's still risks and things I have to think about as a therapist. So who do I go and ask the questions, I think is really important. And Omar, you talk about creating community all the time, but creating a community where I can go and not feel alone is really important, I think. And I think what we hope to do with this course also.
Yeah.
And Leslie, to your point, sitting in a state where we technically have access, but the racial disparities of
Mm,
who has
good
access
point.
to healthcare, I
Mhm.
think is something that we've talked about, right? So can you talk a little bit
Mhm.
about what that looks like where you are and who we're talking to for those people?
So, my state, I live in Maryland. Maryland is a very protective state in terms of abortion care. And I think, Taina, in addition to access for those that might be seeking abortions, we also have to think about provider access. So we know that
Mhm.
depending upon where someone might be training, they might not even be learning how to conduct procedural abortions, or they're not getting that hands on training. They're practicing on papaya fruits, which are a little different than a human uterus, but it's what you have when that's what you have. So one of the things Maryland did was it opened up abortion services to those that could be trained, but also that were certified nurse midwives or nurse practitioners, so that it wasn't so bound within physicians, because so much of this has been bound within physicians. And we see that not all gynecologists want to do this kind of work. In fact, in most states, most of them prefer not to. So that's one piece of it. The other piece that Maryland did too, in terms of expanding access, was that it enabled its state Medicaid to pay for abortion services. And that's a really big deal because we have a federal provision that does not allow federal employees to utilize their healthcare insurance that they have for a valid healthcare procedure if it includes abortion. That's from the Hyde Amendment. So it's a bit of a mess in terms of access. And unfortunately, most abortion care right now is tied to insurance. There are abortion funds that are across the country. And after Dobbs, those funds got a whole rush of money. And now, unfortunately, what we're seeing is that that money is dwindling. And so they really need it, because it's not like people aren't needing the help.
Well, and one of the things that we intend to really talk about in the training, along the lines of what Julie's just describing, is that we want this to be a training that will be accessible to people around the world. And every country, just like every state, has ever evolving abortion access, abortion legal structures. And I think it often doesn't occur to people to think about, how is this paid for here? And what if we have socialized medicine here? Is that automatically in the program? How does this work? What do you have to do? Do you have to go through a panel to get approved? Can you just show up? Where do you go? all of those kinds of things, which we certainly are not going to know about every country around the world. But we want to encourage people to ask those questions and to become curious about that. So when they do have clients come in who say, I just had a termination for medical reasons, they have some idea what they may have just been through as well. How many different kinds of layers did they have to traverse to get access? How long did it take? How were they treated in the hospital setting, for example? What might they have experienced from the medical team? How acceptable is it? Is it newly acceptable? Is it something that has been available but maybe is now not in favor? We see these ebbs and flows. So that awareness of like just how volatile and how labile, I guess, maybe is a better word even, the state of is around the world is important. And again, if you're seeing somebody who's just immigrated or is on a sabbatical from a different place and is talking about their experience, right? That just like we want to be aware about state to state differences. And I think that also it just leaves people so isolated because you can't assume that people, even in an international support group, have faced the same barriers.
Yeah, and just going back to that access piece, Leslie, you speak really uniquely and specifically
Mm.
to people who might not have language access in terms of how they're relating to their providers. So I'm wondering if you can just share with us a little bit about what that looks like for accessible purposes.
Do you mean in terms of, a little bit? When you say, can I speak a little bit? I could go on a bit. But you mean in terms of accessing interpreters even?
Yeah, I think so. I have in the
Mhm.
last kind of 5 or 6 years, I have realized how impactful that can be to a person's. And I know that you have a very specific and unique access into that world due to your specialties.
Yeah. So, a little bit speaking to that, when I said I was fluent in sign language, my profession before graduate school was as a sign language interpreter. So I functioned professionally as a sign language interpreter. I still am a sign language interpreter, but I don't do it professionally any longer. And it just, a lot of what we've been talking about, it just adds an additional layer. A lot of times it's pieces of education, even just knowing, how do you know where to go or who to ask or how to ask? At least in my area, but this is just my area, I'm very specific about that. Accessing interpreters, sign language interpreters, is where people would also access abortion services, is not does not have the same barriers that it might in other areas. But that's just one language. And we're talking about all kinds of different languages. So it adds an additional layer of information, being able to find, because we're often talking about time limited situations, even being in a state where abortion access is legal up to 24 weeks. If we're talking about a TFMR where we might access something at 20, or we might find some information at 20 weeks, or in the last several years where that anatomy scan maybe gets pushed back a couple of weeks, and then we have to find an interpreter, and if providers don't know where to find an interpreter, we're only talking about a couple of weeks. And so that is just another piece of just layers or just complexities and timing pieces that just come to mind for me about it, of knowing how and where to access all of this information.
So I think that the question that I would ask is when we're thinking about those people, those therapists who need that foundational piece versus the therapists who are really trying to work hard to specialize in this piece, is there one or two pieces of advice that you can give for each of those levels? Because I think that we want those people to be accessing. So I guess the other question I would ask is, what are you reading? What are you recommending?
Mhm.
What podcasts are you listening to? Because I don't feel like you get the knowledge and you're done. I feel like it is more this affluent, continuous situation. So can you give us some thoughts about that?
I will tell you what book I am reading. I am actually reading Julie's book. I had to purchase two copies because I ate the first copy and then I had to purchase a second. I didn't really purchase 2 copies, but it was so good. Oh, I just petted it. I pet how beautiful.
Thank you. So certainly that is a great book for clinicians to read, and it's one of the reasons I wrote it is just to give people an entry point when this is not something that they specialize in. I actually just finished a book called Relinquished, and it
Mhm.
is a longitudinal study that looks at women that have relinquished babies, and it's interesting because it's, oh, well, so many people offer adoption as the answer to abortion. This book really made me very critical about what adoption at least looks like in the United States, and I would say probably most places. Really powerful book too.
Well, I'm going to recommend an older favorite, which is Ambiguous Loss. And I think talking about disenfranchised losses and reading about disenfranchised loss is something that I really would encourage people who are new to this area to really understand that there are losses, especially in the perinatal period, that can be so difficult to talk about. And when we're clinically working with people who are grieving, who may be traumatized, maybe multiply traumatized, and their loss is something that they've chosen to keep a secret because there's just too much risk, too much exposure, that we need to be able to navigate those conversations with them, to help them find the words, to help them affirm the loss, even though they may have been in a position to make a choice between horrible and terrible, which is not a real choice. Often the choice is how, not whether. And so I love these recommendations because we've got the experiential, we've got the environmental, we've got the legal, we've got the sociological, we've got all of these pieces here where it's hard enough just to have your baby die, right? Like that should be enough for anybody to have to hold and have to live through and survive and recover from. And so that depth of loss is happening in this very complicated climate in many places around the world. So I think that Unspeakable Losses is the name of one of the books, and then the other is I can't look at my bookshelf right now because I'm not right next to it, but that's one of the classics that I think holds up very well.
Oh, yeah, I remember reading Unspeakable Losses and being so grateful to Kim Kluger-Bell for
Yes.
including
So
abortion and terminating
yes.
for medical reasons as a loss. It
Yes.
legitimized it.
Because people didn't used to
Mhm.
talk about it as a loss. I mean, there was
Right.
just this sort of like,
Mhm.
well, you should just be fine because I don't know, make something up.
Mhm.
But yeah, it's profound. It's really profound. And then the rest of in the aftermath, we have all of the recovery, the grief, the recovery from trauma. We have the relational pieces. We have the identity pieces. We have how do you put yourself back together?
We have spiritual pieces too,
Spiritual pieces.
because
Yeah.
religion comes in a lot for
Very
people
much.
around
Mm.
these kinds of decisions and who is available for them to talk to and perhaps religiously shepherd them through these kinds of decision makings and the grief afterward.
Julie, you made a comment that I just want to dig a little bit deeper into. So, in this space of you can just give your child up for adoption.
Mhm.
I so I've been kind of watching that conversation with this perspective of nobody would adopt my children. Like if my children looked like me,
Mm.
nobody's adopting
Mhm.
those children. So I'm wondering if you can speak a little bit to the discourse of what's happening, not only in the political sphere, but what that looks like overall for people who are trying to navigate really difficult decisions with not necessarily, right? We're saying, hey, we're asking you to give these decisions, and also we are not necessarily giving you all of the right information.
Mhm.
Well, I think one of the things that struck me in reading the book was the difference that a couple $1,000s would make to these relinquishing mothers. That if they had had that kind of support of just a couple $1,000s, they wouldn't have relinquished. They would have chosen to raise the baby themselves. So a lot of times it can feel like, similarly to how we're talking about terminating for medical reasons, is there's not really a choice. It's something that it feels like they're being conscripted or have to do because They don't want to have their sometimes we're talking about a repetition where somebody might have grown up in poverty and doesn't want their children to experience that. Other times we're talking about people who are affluent but whose parents don't want them to raise a child. And so adoption is seen as the answer to that. But yeah, you're right. Adoption is really complicated. And most people that are looking to adopt are people that look more like me, people that are white presenting versus, and so then there's this other cultural piece, which is, okay, what is it like for white parents to raise a non-white child? And how does that child then have connection to their cultures of origin? And how does that child, as they grow up, how do they feel like they belong? I think that's something too that I've heard from adoptees, biracial or multiracial adoptees, that just talk about how it's really hard to grow up in an environment where the information they're getting from external sources is that you don't belong here and you don't belong there.
Yeah, like 15 different levels of complicated. So, funny story. My children are blonde, and I was not prepared for that. So
I have
I'm
that
like,
too. I have a blonde child. We are not blondes. We're like, where did that come from?
what do I do with that? And they are our biological children. We are fortunate that that's a decision that we're able to make. But so I do feel like it does get kind of complicated when people are making these different choices and needing to have information that they might not have access to, of what does that look like for their families, for their kiddos, so that we're not seeing them 25 years later saying, I did not get what I needed.
Yeah. And the thing that I think is a really disingenuous argument that people tend to make when they're talking to an adoptee is, aren't you glad your mom chose not to abort you? And it's like, What?
Yeah.
It's definitely a confabulation of many, many
Mhm.
things.
Many things.
Spoken by a person who's never had to make a difficult decision, right?
Totally.
Mhm.
Anybody who says that does not understand how challenging for the person who is making the decision and for the person who survived that decision.
And I would
I'm
even
not.
say for the family that comes after that decision.
Talk to us a little bit about that, Julie.
Yeah, I think a lot of times, generally with pregnancy loss, the myth is, well, if you have another child, everything will be fine. You
Mhm.
won't have that grief anymore. It's the band-aid that will fix it. And having a child after loss, that pregnancy after loss in and of itself is a very complicated and emotionally challenging 9, 10 plus months that you might be pregnant or trying to get pregnant. And then raising that child who is really here because of the loss. They're here in the shadow of the loss. And that's a really interesting space too. So do you decide, hey, I had to make these decisions and then I had you? Do you say that to your kid? Or how do you balance being authentic to the life that you've lived and not having your child feel like they have to compete with this ghost, this baby who never was? So I think that becomes a really big challenge for parents. And oftentimes, parents are not on the same page about it, particularly because of how, as Americans, we don't really honor and talk about our dead. It's something that we try to avoid. Death is something we try to avoid, generally speaking. So we don't have language or rituals or even just a communal norm that, hey, we can talk about the babies that we've lost. We can honor them. We can remember them. They can live with us even when we have other children, if we have other children. And I want to be really clear, not everyone who is terminated for medical reasons has a child at the end to make everything all pretty and easy and like a rainbow.
Right. And along those lines, just to extend what you're saying, Julie, parents get a lot of advice after all kinds of perinatal losses, whether they're termination for medical reasons or not a termination, and are told all kinds of things about what they should do or shouldn't do, how quickly they should try to become pregnant or not become pregnant, because there is this old idea that parents are somehow trying to replace, but the research doesn't support that at all. Parents are very clear on the baby who died, and our job in part is to support them in remembering and affirming and grieving that baby. And then if they do have another baby, that baby is its own person. And we find that parents don't get confused, but people around them worry that they're going to get confused. And so again, so the complexities of you're here, this child is here, got pregnant before your due date with the baby who died. How complex is that? And yet, again, this is part of what clinicians can do to help support parents in what's our story? How do we tell our story
Yeah.
to each other, to ourselves, to others, to any subsequent child or older children?
Well, I am so looking forward to this content that you all are going to be giving to this community. I appreciate you all. And I'm hoping that we just learn so much more, especially in this challenging climate where we all need support. So thank you all.
Thank you. We're looking forward to it too. Thanks, Tane.